Hello, and welcome to the BloodStream podcast, a show serving the greater bleeding disorders community, brought to you by Believe Limited and BloodStream Media, and made possible thanks to our presenting sponsor, Takeda. I am your patient advocate and host, Patrick James Lynch, reminding you to please speak with a healthcare professional before making any treatment decision. Amy would have told you that, but she's on the road with the Women with Hemophilia film this week, so I am flying solo. Hold on to your seats. We do have another powerhouse episode today. Wes Michael, the founder CEO of Rare Patient Voice, joins, as well as patient advocate and I think emerging friend, dear friend, someone I care greatly for. Suddenly, quickly, I haven't even known him that long. Corbin Whittington. That's coming up in just a little bit. I do, however, listeners, want to remind you that this here BloodStream podcast is made possible thanks to our presenting sponsor, Takeda. Yes, that's right, Takeda. Takeda's got this website, bleedingdisorders.com, where you can learn all about Takeda's resources for and commitment to the bleeding disorders community. Takeda believes in a world free of bleeds and is dedicated now more than ever in their efforts to offer a wide range of programs and support to help the patient journey wherever on that journey the patient may be. You can learn more by simply visiting bleedingdisorders.com. One more time for the folks in the back, bleedingdisorders.com. And for their founding and ongoing support, I would just like to say thanks, Takeda. By the way, shout out to Julie Kim, the incoming CEO for Takeda. She will be taking over that role in 2026. And the reason that's relevant is because Julie Kim was once upon a time a member of the Greater Bleeding Disorders Division at Legacy Takeda. So she has a deep personal experience with that work inside the company and will now be ascending to the highest chair. I made that sound very monarchical. I haven't even been watching those kind of shows, or I would blame it on that. Point being, though, it's great for us to have an ally who is at the big seat at Takeda. So congratulations to Julie, and I look forward to seeing what that means for the bleeding disorders community. So I'm alone, and given that, I want to take the opportunity to kind of go deep on something that otherwise may not have had the opportunity to. You know, I've been doing this podcast now for the last 8 or 9 years, and over that period of time, I've noticed a few things, but something in particular. There are times when the news cycle slows down, when the updates are minor and nothing seems to shift in any major way that's relevant for the vast majority of patients, caregivers, and the clinicians in our community. And then there are the times like, right now, when it seems as though everything's happening at once. And we are indeed currently living through a peak period. There is a lot going on the federal level, on the state level, on the worldwide level, the private sector, funding, access, drug development, within the advocacy organizations, just everywhere you look. Not to mention global events that further complicate everybody's availability. Not to mention global events that further complicate everybody's ability to navigate life, but especially if you are managing a bleeding disorder. So today felt like a good opportunity to walk you through some of the biggest updates of the last couple of months, because while we've been in the middle of holidays and the new incoming administration and households with kids getting a winter sickness just circulates and lingers for like 4 months, we've been a little distracted. So I want to make sure that we haven't lost any of the important news and updates of the last several weeks amongst all that busyness. So with that, I would like to bring to you some of the most important updates as it relates to treatment, availability, policy, advocacy, and more. Like I said, hold on to your seats. I want to take the opportunity flying solo today, though, to go a little deep on something important. Having done this podcast now for about 8 or 9 years, can you believe it? I've noticed something. There are times when the news cycle slows down, when updates are minor, and nothing seems to shift in any major way for most people in our community. And then there are times like right now, when everything seems to be happening at once. Right now, we are in a peak period. There is a lot going on. on the federal level, state level, private sector, funding level, access level, drug development level, and within advocacy organizations. And of course, there are the global events that further complicate our ability to navigate life, especially if you have a bleeding disorder. So today feels like a good opportunity to walk you through some of the biggest updates from the last couple of months, because we've been in the middle of the holidays. There was a new administration that took over in the White House. The Super Bowl just happened, just winter, everybody gets sick 6 times. There's things happening, but beneath it all, some critical things have been going on in the world of bleeding disorders that you may have missed. So I'd like to take you through some of those developments to let you know what you may have missed. I want to start with some of the biggest from a federal government policy and advocacy perspective. So let's talk about some of the new treatments that have hit the market, some of the legislation that could impact access and affordability and beyond. So number one, the FDA approved Alhemo for hemophilia A and B with inhibitors. So at the end of 2024, the FDA approved Alhemo, known as concizumab, now commercialized as Alhemo, for people 12 and older with hemophilia A or B with inhibitors. And as mentioned not too long ago here on the pod, this is the first subcutaneous therapy available for hemophilia B with inhibitors, which means instead of the regular IV infusions, a factor, of course, patients with hemophilia B and inhibitors now have a subcutaneous option for administration that may help improve adherence. Alhemo targets tissue factor pathway inhibitor, or TFPI. So it offers a new mechanism for achieving hemostasis, which is what many of these novel therapies are doing, targeting new areas of the coagulation cascade. So that's something important to be aware of. And I should mention, we covered this in depth on the Global Hemophilia Report. We did an episode recently exploring novel therapies and how treatments like Alhemo are reshaping inhibitor management. So I would encourage you to go check that out. We may even have a link in the program notes. Something else we did touch on, but I want to highlight the fast track status that was given to VGA039, the first subcutaneous therapy being investigated for von Willebrand disease. So this would be the first in-class subcutaneous therapy for all types of VWD, 1, 2, 2AB, a lot of different types. This one is intended to treat them all. It's a monoclonal antibody that targets protein S. That's a key clotting regulator, again, a different target than we're traditionally used to hearing about when it comes to hemophilia treatments. Protein S is the target of VGA039. Bottom line is this could be a treatment option that provides an infusion-free or a fewer infusion way to manage your von Willebrand disease. As we know, people with VWD have not historically had a whole ton of options. So if this is indeed approved, it could be a major breakthrough. The first FDA-approved non-opioid pain medication in, I believe, decades has just recently come to market. The FDA recently approved Jernavix, a non-opioid pain reliever that was developed by Vertex Pharmaceuticals. This is the first in class, as I said, in decades, and it works by blocking pain signals at the sodium channel level before they even reach the brain. Now, why this is important and being mentioned here is that for people with bleeding disorders like me, pain management is a huge issue. And many of us, myself included, have over the years sought non-opioid alternatives to pain management. Again, consult your HTC and your healthcare professionals before making treatment decisions, but do be aware that there is now an acute, moderate to severe acute pain drug available, non-opioid. The National Bleeding Disorders Foundation and Hemophilia Federation of America have had some advocacy updates that I want to shine a light on. So Washington Days takes place every year, usually in the first quarter of the year. It brings together members from across the U.S. to Washington, D.C. to meet with lawmakers, share stories, and advocate for the policies that directly impact our care. This year, a couple of notable points to highlight. Congress is considering a $2.3 trillion with a T cut to Medicaid and a $151 billion cut in or reduction in Affordable Care Act spending. So if this bill that is being pushed forward is passed, it could result in millions of people losing coverage. And for people with bleeding disorders, that means reduced access to factor or your therapy, increased costs, and fewer overall options. Medicare enrollees will now have a $2,000 out of pocket cap on prescription drugs. That's a positive, but factor therapies are covered under Medicare Part B, not Part D, meaning the cap does not apply to most people in our community. So good news in general, but the details, unfortunately, that does not apply for many of us. And a federal funding freeze on health programs could obviously impact research, surveillance, and access programs for rare diseases. So what can you do about it? Well, if you've never participated in Washington Days, this is the year to step up. March 5th through 7th, it's taking place in Washington, D.C. Registration has now technically closed, but I would strongly encourage you to reach out either to the National Foundation or your local chapter to find out how you can participate. And even if you can't attend in person, you can still email or call your representatives. HFA and NBDF both offer tools to make that kind of outreach easy. Your voice matters, so whether you're going to DC or engaging with policymakers from home, do not sit on the sidelines during this critical period. I also want to applaud the National Bleeding Disorders Foundation for recently reaffirming its commitment to health equity, emphasizing that care must be accessible to all members of the bleeding disorders community, which includes women, members of the LGBTQIA+ community, rural and non-English speaking families, and all of those who have historically been left out of research and patient priorities. NBDF is also pushing for inclusive healthcare policies nationwide to ensure insurance providers don't put up new barriers to access, which is a game I feel as though we're always trying to stay one step ahead of. So just keep in mind when we talk about advocacy, it's not just about government policies, it's also about working with insurance providers and making sure that access is there for all who need it. The Hemophilia Federation of America, they recently pushed back on this funding freeze that threatens key programs for many of our community members, such as the Ryan White CARES HIV/AIDS program, blood disease research grants, and surveillance and prevention programs for blood disorders and the blood supply. HFA noted that more than 500 community members have already contacted Congress to oppose these cuts. So if you are not one of those 500 people, step on up, reach out to your state and federal representatives and make them aware of why these cuts would be detrimental to your life. All right, that was a little bit of drinking out of a fire hose, I'm sure. I hope, though, you heard something that helps you manage your life with a bleeding disorder just a little bit better. So there's some updates on emerging therapies, policy shifts, and major advocacy efforts. I think 2025 is going to be a pretty big year. And how do we make sure that all patient experiences are actually shaping research and decisions being made about policy, access, or the investigation of a new treatment? Well, funny you should ask, Patrick. Well, thank you, Patrick. You're welcome, Patrick. Because Wes Michael is doing exactly that with Rare Patient Voice. Wes Michael, who's been on the podcast before, he is the president and founder of Rare Patient Voice, and it's a company that connects patients and caregivers with paid research opportunities to make sure that industry leaders are listening to the real-world lived experiences of those who rely on these treatments and services. We had the chance to sit down with Wes recently to talk about the importance of patient voices in research, how Rare Patient Voice works, and how you, our listeners, can get involved. Here's that conversation.
BloodStream listeners, Keith back here with you, completing my hostile takeover, the BloodStream podcast. But we're thrilled to have Wes Michael with us today. He's a market research veteran with over 40 years of experience, an MBA from the University of Chicago Booth School of Business, that's down the street from DePaul, my college, and the founder of Rare Patient Voice, a company dedicated to empowering patients and caregivers by giving them a platform to share their voices. And it says here, beyond his professional work, he also enjoys walking his dogs, playing the piano, and exploring history. So I say
you got all that. You've done the whole investigation there. So
yeah, I say we get rid of the hemophilia questions and we go straight into history in Chicago and just hijack the whole thing. But Wes, welcome to the show.
Hey, great to be here. You mentioned the University of Chicago. It's like It wasn't called the Booth School when I went there. Long afterwards, someone gave him a lot of money. It must have been named Booth, obviously. So.
Yep, they gave my school a lot of money too, and it improved drastically after I graduated. But
Yeah, yeah.
so, for listeners who have not heard you in your last appearance at Bloodstream, can you briefly share what inspired you to start Rare Patient Voice and how it's evolved?
The funny thing is, because we work with 1,500 different conditions and diseases now, but hemophilia was the inspiration. For better or for worse. So many years ago, in the late 90s, I was working for a research company, and a company came to us and said, we have a product, we have a blood factor for hemophilia A and B, and we want to learn more from people. What do they need? What are their families? Not just about the drug, but about their lives. We want to get into their heads. We want to learn a lot about them. Can you create a group of folks that we could do surveys and interviews and find out more about them? And we're like, well, we'll try that. And we went to, at the time, the National Hemophilia Foundation annual conference and had our table and flipboard. It's pre-internet. I mean, the internet was around, but we weren't using that yet. And giveaways and such. And in that time, boy, the late 90s, it was still a whole generation of patients had been wiped out. And it was just what an experience. But anyway, people were very interested. They were very interested in sharing their experiences. They signed up. We did a lot of work for that client over the years, and fine, that could have been the end of it. But every year we go back to that conference to give new people a chance. And it moves around a bit, so it's great. You get people from different parts of the country. And a different client that's also in the hemophilia space came up to us, said, "I hear you have this panel. Can we access it?" Well, no, it's client A paid for it. I can't give it to client B. But that moment gave me the idea. It took me 10 years to do anything with it, but wait, why not create something where it's not beholden to any one client, and we can do a lot, and people can get involved in all sorts of things. And I didn't know whether it would just be hemophilia, because I've been involved in that. There's been so many new things going on there now for decades that in itself was something. But no, that was just the first. And now again, we've done 10,000 projects, and we've covered, as I say, 1,500 conditions, and very exciting. We pay people for their time. We paid out $15 million from that first study where we got a few people and gave them $100. So 15 million for people to share their opinions. So who knew? Who knew? Going to that hemophilia conference, and I remember I was naive, right? I didn't know anything. What did I know about hemophilia other than what I was reading on the brand new internet at the time? And I made the mistake when I first emailed the foundation. I used the word hemophiliac. Oh my God! Did I learn that was not? And since then, so many people say, I don't mind. But oh my God, I thought I'd stepped on a landmine. I'm like, I didn't mean it. I'm not offending anybody. I'm so sorry. People with hemophilia, the bleeding disorders community, I had to learn. But I was like, oh, I didn't mean to offend anybody.
Well, that'll teach you.
Exactly. So I learned my lesson quickly there.
So what shifts in patient engagement have stood out to you over the past few years beyond financial incentives? What truly motivates patients and caregivers to participate in the research?
Yeah, no, that's interesting, because when you ask people, and I love to go to the conferences, the walks, whatever it might be, where people are there, we'll say have a table set up, and people say, "Oh, I do that. I love that." And why? The first thing people say is invariably, "Hey, could this help me? Could this help my kids? Even if it doesn't help, could it help those coming after?" Because any kind of research, that's the only way, right? Whether we're making a huge progress or tiny steps at a time, that's the first thing people say. And it's not until after a while they go, and the money's nice too. And then we because we've heard from people where, "You made my holidays happen. I gave a few extra $100. I was able to do this. Thank you so." But that's not what they're leading with. That's not the heart, the motivation of, hey, if I can tell my story, and it gets into because if you're an executive at some company, yeah, you get charts and graphs and data, right? And that's important. You need all that, but that doesn't stick in your head like, oh my God, we just talked to a mom and she has 3 boys and 2 of them have inhibitors. That's what sticks in their heads. Is like, how can we help this person? I don't know if people realize how impactful their stories are, but they seem to get that's how they can help the community. Long after we're all gone, they can help people.
Oh, that's great. So, Rare Patient Voice now spans multiple countries and disease communities. So, how's your research expanded in the past year or two, and where do you see the biggest opportunities for growth moving forward?
Yeah, interesting, because my background was in, quote, market research, surveys and interviews that help companies learn about folks. And that's what most of our work has been. You know, people get a Zoom interview or sometimes people come to their home with a camera and want to see what their life is like. But there's a whole other worlds out there where people want to talk to patients and their families. One is an obvious one, but wasn't in my radar. Clinical trials, right? None of these treatments, these breakthroughs happen without clinical trials. Yeah, people have to try stuff. Eventually it gets good enough for people to try it, and let's see if it works. And even we found out it's like a different world. People speak different language. In market research, we talk about screeners, and clinical trials, we talk about inclusion criteria. And we talk about sample, and they talk about subjects, and neither of them are very good words. But for us, it's like, wait a minute. When we have a study for someone, we do something very simple. We say, okay, we try to match it up. Hemophilia B study. Here's a hemophilia B patient. We don't want to bother an A patient. You know, let's send. And all we do is send them an email, and then boom, they can decide if they can qualify. Well, it's no different for us with a clinical trial. There's a certain one. We can send an email, and again, there's a lot of steps people go through. They need to talk to the doctor. They need to. We're not pushing. We don't want to push anything on anybody. But it's a similar thing to us. We have people that are interested in research, and we send an email and invite people. So that has been a big area for us. It was just outside of my radar because that wasn't the world that I had been involved in. And you know, talk about helping people. If we can get, you know, more things approved, that what slows down progress are these clinical trials. They can't get enough people. They go slow, et cetera, et cetera. Hey, we're not going to solve that, but if we can help a little bit here and there, invite people that are looking for that kind of a thing for themselves or their kids, hey, we're happy to put them in touch.
It's great. So artificial intelligence, my current favorite subject, it's reshaping industries across the board. So how's rare patient voice adapting to AI and other emerging technologies? And do you then see these tools that they'll enhance patient engagement, or are there challenges ahead that are concerning for you?
Well, it's a very interesting thing. It's certainly a double-edged sword for us in a lot of different ways. On the one hand, some bot in some other country can fake being a patient and be pretty convincing at it, right?
Yes.
Pretend I'm a hemophilia patient that's 27 and this and so we're like, whoa. On the other hand, we can say, wait a minute, here's people signed up. We look at it manually, but can AI also look at that? Does the treatments and the drugs they're using match their disease? You know, so it's like offense and defense, using it like on both sides. One of the real interesting things in our field is there's a new thing from AI they call synthetic respondents. Doesn't that give you the creeps? It's like fake people. Mm-hmm. And at first it's like, well, wait a minute. Companies don't, if you're going to have some advertising concepts, you want real people to look at them and get feedback and decide what you're doing or any kind of work you're doing. But wait a minute. Before the company gets 10 advertising concepts, they might have 100 on the table. And how do they whittle it down? Well, they get their MBAs in the back room and say, they're not real people. They're not the regular patient. Why not have the synthetic respondents whittle it down and then take it to real people? So I think there's a real use for this. But we have to be careful. We don't want to take real people out of the process. And none of this happens without real people to begin with. You can't create one out of thin air. You got to start with real people. So we're looking at, I don't want to sit back and find it's passed us by. I want to do it and take control of it. And if we use folks for it, I want them to be rewarded for it, whether they were used real or some artificial version of them was used, to make sure that people get credit for the input they've done. And then on the research side, you know, you get all these surveys, right? And you get all this data, and you go through open ends, right? And people love to do open end, you know, give response. We love that when we ask a question: how did this affect you? Boom, they write it all out. Well, in the old days, you read, you summarize, summarize. And you can say, and I've done this because mostly we don't do our own studies. Usually our clients do it. We don't even see them, but we do them ourselves that present at conferences and things. And you say, go through these 2,000 things, read these open ends, summarize the 10 points of that they're making, and give me 2 good examples of quotes for each. Mm-hmm. And that would have taken me all day. In seconds, I have it. Now I want to go back and check because there's what do they call it, hallucinations and things. But oh my God, it's making that analysis work so incredibly efficient. So I've loved that part of it, but you just got to be careful. One more thing, when ChatGPT came out, when it first was out several years ago, we were all playing around with it, and I went in and I say, tell me about rare patient voice. And it came back, and it was pretty good. It said, this company does this, that, and the other. And it was founded by Wes Michael, and it mentioned a woman's name I had never, ever heard of. And then I since linked in with her because I found out she was in the rare disease community. And so but it's like, who knows what it was basing it on. So you better double check these things. But they certainly have a place, and I don't want to be left in the dust, while people are moving ahead with that. But you use it for offense and for defense. We don't want the bad guys to take control of that.
Yeah, absolutely. What's really going to bake the noodle of our listeners is, are we AI right now?
Exactly.
And that's coming at some point. Okay. So hemophilia, von Willebrand disease, and other bleeding disorders have long been a part of Rare Patient Voices work. Based on your experience, Wes, how has patient engagement in this space evolved? And what unique challenges or opportunities do you see today?
Now, it's funny. When I first went to those initial conferences, I remember people were like, what are you talking about? Somebody wants to talk to me? They want to pay me? Now I call the bleeding disorders community survey savvy. They get it. They know it. They know they have some value. I'm like, yeah, we love you guys, but you know it now. So over the years, people have just gotten, sophisticated about it because the world has changed. There's so many opportunities, and that's a good thing in that means companies have been asking, because it means in the old days they weren't. Nobody knew, but now people are used to it, and they're asking. So people are just more savvy about that whole thing. Going forward, I think the key is, I tell people, don't be intimidated. You know how when you ask a politician a question, they don't answer the question. They say whatever they want to, right?
Right.
Well, you can be a politician in that regard. If somebody's asking you certain things that are uncomfortable, you control the conversation. They're not going to kick you out. So don't let people throw you off your base there. Just make sure you get your point across, and feel empowered, right, to tell the story in your own words.
All right. And the final question, looking 25 years ahead, where do you envision Rare Patient Voice? And
my goodness,
go ahead, answer that question, then I'll have one more.
Oh my God. Well, I don't know. We're 12 years old now, so when we were looking back 12 years, I thought, well, maybe it'll just be me working on this stuff, and we'll do a few hemophilia studies. Now it's like all these other people doing all this wonderful work. So if it continues like that, I don't know. Hopefully a lot of diseases will be cured by then, and we won't need to be researching people about certain ones. I'm not worried about that putting us out of business, unfortunately, because there's 7,000 or 10,000, depending, rare diseases, and even in 25 years, I don't think we'll have the whole thing solved. But wouldn't it be good if we did? And I'm 67, so I'll long be retired, so it'll be okay if it puts us out of business. But I just, hey, the world needs to hear from people, and just so more of that in every direction.
All right. For patient advocacy leaders working today, what's the most important priority they should focus on to help make that vision a reality?
And I'm sure the specific advocates have, know what the issues and stuff that they face are. But looking at it generally from my point of view, I am amazed that people don't know that much about the advocacy groups. We'll go to these events. They're sponsored by an advocacy group. They're put on by an advocacy group. Well, then we'll do a survey among the folks, and we'll say, what do you think of the advocacy group? And they'll say, huh? So don't assume that they know that. Don't assume when somebody's diagnosed, say it's a child, say it's a spontaneous mutation, the family doesn't know anything about it. Don't assume when you've told them that and said, and there's this organization that can help. They're not going home saying, oh, and they're not remembering a single word other than they told us we had this thing. We had von Willebrand. They don't know anything about this stuff. So that just to raise awareness, just to say, no, we do exist. Don't assume they've heard you. Don't assume they've heard you the first time. Get the word out that they can help. So many organizations I've heard, a guy that works with us works with in MS, and he'll say, people don't realize there's help out there. There's people that'll supply them wheelchairs or fix this or do that. And people are, I don't know, there's nothing I can do. No, there's a lot of help out there. So these organizations are doing such wonderful work. Shout, get to the top of the mountain and yell and tell people. Don't assume they know. Don't assume doctors and nurses, even though they might be doing it. do whatever you can. Tell them 10 times, because they're not hearing it in those moments of diagnosis. They're not hearing it in the hospital when the baby's born, whatever it might be. You gotta reach back out. So that's to me is raise awareness. You're doing wonderful work. People don't know about it as much as they should.
Perfect way to wrap up. Wes, thanks so much for joining us on BloodStream.
Hey, a pleasure to be here. I'll come back in another 25 years and we'll see how close I was.
I think we can do sooner than that.
If you're interested in learning more about Rare Patient Voice, or if you'd like to explore how you can participate in research opportunities, I would recommend you do. Visit rarepatientvoice.com or check out the link in the program notes. All right. Now, while we've been talking about treatments, research, access, I want to shift to something that I believe is critical, and that is the personal story side of advocacy. Corbin Whittington is not just an advocate. He is someone who understands firsthand what it means to push for change, whether it's tackling access barriers, raising awareness, or navigating life with his own chronic illness. Corbin's story is one you need to hear. And with Washington Days just around the corner, there really is no better time to have this conversation, because again, advocacy, it's not just about policy, it's about people and their lived experiences. And it's about making sure those experiences shape the decisions that impact our community. So let's get into it. I am very excited to present to you my conversation with Corbin Whittington. Corbin Whittington is a leader, strategist, engineer, and advocate. He has led technology teams across the globe, advised Fortune 500 executives, and today he's at the forefront of rare disease advocacy. Corbin's journey took an unexpected turn when he was diagnosed with not one but two life-threatening conditions. Doctors told him survival wasn't an option. Yet, today, he's here, defying the odds and reshaping the future of patient care. Corbin's is a story of resilience, innovation, and the power of one person's determination to create a lasting change.
Originally, I was diagnosed with a heart condition, which is dilated cardiomyopathy, which is typically a fatal diagnosis. Found out that I also had this condition called CIDP. Upon diagnosis with that, my mission was, how do I beat these odds? Because what I found out was there was a very tiny sliver of people who survived the condition that I had. And it was worsened, those odds were worsened because I had CIDP. So when you put all it together, the doctors, I went some of the best in the world. And, they all said, no, this is going to be terminal for you.
Imagine hearing those words, the finality of it. But Corbin didn't take it as final. Instead, he put his mind to work in a way that only he could, engineering his own survival.
So I looked at my condition as, okay, this is a problem to be solved. So I made that my focal point, my life's mission to go forward. And how do I resolve this? How do I find those incremental opportunities to improve as I go along? And that's what I did going forward. Worked through about 5 different hospitals along the way. A lot of different experts in cardiac and neuromuscular and et cetera. And incrementally found little opportunities here and there to be able to tamp this down. We had to take some chances with experimental things and do some other things. The survivors tended to be people who were a lot younger. The odds were pretty stacked against me, but I had to find my way through all that maze to get access to the best in the world, to get them interested in my case, to find those slivers of opportunity, new technologies that came forward, new medications that came forward.
The odds were 98% against him. He was given a 1.8% chance to live. Not even 2. But Corbin had already decided he wasn't going to become a statistic.
And in 2022, I beat those odds. 10 years had gone by. The doctors informed me, hey, to our surprise, you beat those odds. We believe you're stable. We believe you're going to stay stable. And here it is 2024, and I'm still moving on just as strong as I was then, if not stronger today. That's kind of it in a nutshell. I'm a survivor. And you hear those survival stories, but yeah, I'm one of those folks. I survived against very rare odds. I made some some troubling decisions, some risky decisions. Had several conversations with my wife and kids, thinking, okay, we're going to go into this procedure, or we're going to try this thing or try that thing, and nobody really knows how it's going to turn out, but we're going to give it a shot. And here we are.
Corbin's survival wasn't just luck. It was strategy, determination, and an unrelenting belief that there had to be another way. And that belief? It's now at the heart of his mission. Before we move forward, let's take a moment to clarify what exactly Corbin was up against. Corbin was diagnosed with chronic inflammatory demyelinating polyneuropathy, or CIDP. It's a rare autoimmune disorder where the immune system mistakenly attacks the myelin, the protective covering of the nerves, causing progressive muscle weakness and paralysis. Left untreated, CIDP can be debilitating or even fatal. But what played a crucial role in Corbin's survival was plasma-based therapy. Through intravenous immunoglobulin, or IVIG, derived from donated plasma, Corbin's immune system was stabilized, slowing the attack on his nerves and giving his body a fighting chance. Plasma donors, strangers he never met, helped save his life. That was the experience. Realizing how deeply human this type of medicine is, that would later shape Corbin's advocacy.
The patient community with rare conditions, particularly neuromuscular conditions, it's not equitable in how they're treated, and their outcomes are not equitable. So we're not talking about just those in the United States that have access to health care because they got great insurance and they get some of this treatment, which is like 20 grand a month. You need great insurance, right? Or you've got Medicare for certain elements of it and so forth. But all those other folks that are marginalized, what about them?
The reality is, too many people don't get the chance to fight. Corbin knew that had to change.
I'm currently the chairperson of the board of directors and president of the GBS CIDP Foundation International. So the focus I had getting involved with this was, how do we take this engine that we've created in the GBS CIDP Foundation, how do we create this engine and carry it forward to, the world, right? And if we step outside of the boundaries of the United States, and one of our board members, we just brought her on when I was interviewing her a couple of years ago. She's from Mexico. And the first thing she told me, she says, Corbin, the children of Mexico cannot get access to the IG medications. What are we going to do about that?
Healthcare should be about access, not privilege. And Corbin, he's making sure that message is heard loud and clear. Corbin and I met at the Plasma Protein Therapeutics Association at an event at the end of last year, where I learned that he, like me, has depended on plasma-based therapies at some point in his life. I also recognized that he, like me, feels passionately about their importance within the greater healthcare system. One thing that struck me in our conversation was Corbin's deep understanding that beyond the medicine, there's something profoundly human about plasma-based therapies, something that connects donors and patients in a way few, if any, other treatments do.
People need to visit a plasma donation center. I went to visit one plasma center in Fayetteville, North Carolina, and I met this one woman, and she said, oh, I got to call my mother. And I said, okay. She said, and she gets her mother on the phone, and she says, hey, Mom, I'm talking to a patient. Her mother was a lifelong plasma donor, and now she's a plasma donor, and her sister was a plasma donor. This is their way of giving back to the community. I talked to plasma donors, they had tears in their eyes when they came and met me, and we're meeting, and I'm telling them my story and my survival story. It brought tears to their eyes because this is what they were trying to do. So we have to get past this stigma that says, we're using human beings to help solve problems for human beings. I think we just need to understand plasma from a biological perspective and not from a stigma of that is taking advantage of people somehow. the J. Griffiths Foundation, we have one of our board members, and she been donating plasma. I don't know how many years, but she's like, how many thousands of pints of plasma she's given. And Vicky does that in Victoria. Vicky does that because that's her way of helping humanity. And the people I've talked to, this is my way of helping humanity.
If Corbin's story or mission has inspired you, I would encourage you to visit the GBS CIDP Foundation to learn more about advocacy and rare disease support. And for those interested in plasma-based therapies and their role in healthcare, please visit the PPTA Global website. Links to both can be found in the program notes. Thanks again to Wes Michael, Corbin Whittington, and for all who helped support today's program. As always, a big thank you to our presenting sponsor, Takeda. Visit bleedingdisorders.com for more. We could not produce this show without your support, and for that, we are grateful. Before we go, if you found any part of this episode valuable, please share it with a friend, colleague, family member, a clinician you work with, a patient you know. That is the best way to make sure the content information on BloodStream reaches those who need it the most. Of course, you can find BloodStream Media and the BloodStream podcast on social media. You can also reach out to me, Patrick James Lynch, or my colleague, Amy Bradford, on any one of the various social media platforms that we may be on. We'll be back again in 2 weeks' time with another fantastic episode. Subscribe if you haven't already, and be sure to tune on back in. My name is Patrick James Lynch, and until next time, take self-care of yourself. Bye, everybody.